Good evening. So welcome to today's General Club presentation. We are glad to have Dr. Nourou to take us through the General Club presentation for today. And before we can get into the presentation, I'm going to call upon the panelists to introduce themselves. So I'll be calling the names as they appear on my screen. So we're going to start with Michael.
Hi, everyone. My name is Michael. I'm a fourth-year medical student from the Philadelphia, from the USA. Thank you for having me today.
Thank you so much, Michael. Then we have Kisao.
Hello, everybody. I'm Nisao Kisao. I'm resident, 40-year resident in Dakar. Glad to have you, everybody. Nice meeting. Thank you.
Thank you so much, Dr. Kisao, and we are glad to have you with us today. Then we have Credo.
Okay, hi. I'm Credo Indas Ngujade. I'm a student of last year in medicine at Dakar.
Thank you so much, Credo.
Okay, thank you.
Then we have Chinedu.
Yeah, hello everyone. I'm Chinedu Tengu, currently in the UK, a junior doctor in Queen's Medical Center, Nottingham. Nice to be here. Thank you.
Yeah, I think David has issues with his audio. So I think we're running a little late. We should go ahead and just start. So Dr. Nourou, please go ahead and start the journal club.
Okay, great. Then we should start. So hi everyone, I'm Dr. Nourou, postgraduate of 5 of Neurosurgery Resident from WF Training Center. It's a pleasure to me this evening, this afternoon to run the journal club. Okay, I could not share my screen, but it is okay. So we should talk today about this article, endoscopic third ventriculostomy and ventricular peritoneation for patients with non-communicating hydrocephalus, a prisma complaint meta-analysis that I think that all of you, you try to read that before. And usually we use some template to review article. And this session should be also interactive. To best of my notice, we should go ahead about to review the abstract, the title, the abstract, and the introduction, the methodology of this paper, and then the results, the discussion, and the conclusion. And then we can make some suggestions or amendment or comments if we have. So thank you everyone to come, and if everyone is okay, we can start right now.
Yeah, sure, we can start.
Okay, great. I don't know if I could share my screen or not.
Definitely. You can go ahead.
Okay, right. Okay, so please remember about this paper. What do you think about the title? Of the paper, and I will ask you if the aim in the abstract was clear. Did you get the aim of this paper? Did you get the aim of this paper? Is it clear for you the aim of this paper? Someone can answer. It is an interactive. Yeah, go ahead. Yeah.
Greetings, everyone. Yeah, for me, the aim, which is being reflected from the research question, was very clear here. Like they are trying to compare between the ETV and the VS, which one is more effective. Yeah, there's which one more effective, which one has lesser complications, and which one has a better outcomes. That's basically what the aim of this meta-analysis is all about. Thank you.
Okay, thank you very much. Are you all of you agree with what he said? In my opinion, yeah, the aim is clear also. And I have another question if no one don't have anything to say about the first question. Okay, perfect. So is it clear what the study found and how they did it? Is it clear for you what the study found in the result and how they did it? Is it clear for you?
So hello.
Yeah.
I think, in my opinion, how the study was conducted and like just basically how the study was conducted is quite clear. Looking at the methods that were used, and that is also stated in the title itself, because remember the title also has to give the methodology that is being used in a particular study. So in this case, we can see that this was a PRISMA compliant meta-analysis. So from that alone, it can give you ideas, or rather an idea of how the study was conducted and how exactly they went about it.
So that is good, but it's not very specific to the study. Can you answer the question based on the study, on a specific study? You want to be as specific as possible. Your answer can be applied to almost any systematic review. In this case, how do you feel about the methodology? Always try to be as specific as possible. Let me put it this way. You have a study that is evaluating, like Bejo highlighted, evaluating endoscopic ventriculostomy, right? Versus ventricular shunt. So the first thing that you want to ask yourself is, if you're thinking about evaluating these methods and you're going through a systematic review meta-analysis, then you want to respect the PICO guideline. So the question now is, was the population clearly defined? And if it's yes, what was the population? Were the interventions clearly defined? If yes, what were they? Were the comparisons clearly defined? If yes, what were they? And were the outcomes clearly defined? That's how you should look at this. So starting with the population, what was the population evaluated here? Measure what was the population. In the meantime, Darwin, please reshare the link to the article in the group in the chat. I think a few people didn't go through the article before joining. Please reshare the link so that they can always take a look. Bejo, what was the population in the study?
Thank you for the question. The population was patients who had non-communicating hydrocephalus.
Again, that's not very specific. What about the age range? So what we're trying to, if everybody sees the link that Darwin has shared, you can access the article for free. It's open access, so you can click it and go on the website. Just what we're trying to do here, just as a reminder, this is not meant to be a quiz. Remember that a lot of studies get published, and your question as a physician should always be, when a study is published, do you just take the results at face value? And the answer to that should be no. You should always have a critical appraisal of a study. And so when we're doing a journal club, the goal is to have a critical appraisal and asking ourselves the questions about what was studied, was it relevant, was it done the right way? If we had to do it ourselves, how would we have done it differently? If we're giving results here, can we trust those results? And you always need to think about that in your practice. This is very important for practice because you'll see a lot of studies that will come up. And if you're not careful with the inclusion criteria, you will just apply them to everything. There's a good thing that you mentioned, the type of hydrocephalus. So the first thing that everybody here should keep in mind is that this comparison is for a very specific type of hydrocephalus. If you're not, you cannot apply this result to every single type of hydrocephalus. If you remember, there's non-communicating and communicating. You want to just look at it grossly. And here we have a very specific population. And in terms of population, this is very focused on pediatric population. So yeah, so please look at a study, and even with the abstract, you already get an idea. You can go ahead, Dr. Nourou.
Okay, thank you, Eric. So like you mentioned, Bergeau breakdown. So yeah, this article meant to compare ETV with versus VP shunt in non-communicating hydrocephalus. And the mean age that they come out is the mean age from some study was for 4 years to 35.5 years. So after that, when you take also article, you should also after your first look about the title, is it informative and relevant for you? When you see this title, did you see that is relevant the title of that the author proposed used for the paper? Did you think that this title is informative and relevant? For those who already read the paper, you can just unmute yourself and answer, please.
Greetings. Please, can I take this?
Yeah, you can, definitely, you can. Thank you. Go ahead, please.
Okay, thank you very much, Dr. Nourou. For the title, I was also thinking that when you check at the level of the abstract, you see that the studies there were 10 studies, those that were included, there were some observational studies there, prospective and retrospective. So I was thinking that instead of putting maybe a meta-analysis, it would instead have been better to instead change it to a systematic review. That is my own opinion for the title.
Okay, so you agree that it is informative and relevant?
Yeah, it is. I'm kind of saying saying that for me, like, the abstract and the title, there's a bit of a discordance.
Okay. Okay. You found discordance little bit.
So I'm going to go ahead with an answer.
They say that. Yeah. Okay. Go ahead. Thank you.
So it's important, first of all, to have some background, and the way you determine if it's relevant, you base it on your previous knowledge, but more importantly on the introduction. In the introduction, the author will give you information about what is known and what is yet to be known and why they're doing it. So if you're looking at this paper, what you see is they give you information in the second and third paragraph about the importance of comparing ETV versus ventriculoperitoneal shunts. So the question has always been this: when you place a ventriculoperitoneal shunt in a patient, ventriculoperitoneal shunts are known to fail, to stop flowing. Another problem with them is that when they get obstructed, then you have to change them. So that means taking the patient a few times to the operating room. And then the other thing is the question about alternatives. So one of the alternatives that has been proposed is the scopic third ventriculostomy, which has been proposed as a shuntless alternative. Shuntless because you create this diversion of CSF flow, which doesn't need a ventriculoperitoneal shunt. And in theory, what should happen is the patient should never need another surgery. But the question that the authors are asking now is, in the very specific case of non-communicating hydrocephalus, which one is above? Now, getting back to what Bergeau said, Bergeau, technically, you cannot have a single study be a meta-analysis only. The meta-analysis is done after you've done a systematic review. So a meta-analysis is not a standalone study. So technically speaking, this study is actually a systematic review with meta-analysis. So you do the systematic review first. The systematic review is the process of you going through the different databases in a systematic fashion, coming up with search terms, narrowing down through screening of articles. But that stops there. That's systematic review. Now, the meta-analysis is when you go into those included studies, extract data, and then compare to see, for example, which of the two or three interventions is superior to the other one. And then added to that, you equally go ahead to evaluate the quality of evidence. What you mentioned, Bergeau, is what is the quality of evidence. When you're talking about observational studies for those that might not be familiar, is anything ranging from cross-sectional studies, case reports, cohort studies, case control studies. Those are observational studies. There is no specific intervention. Whereas interventional studies are things like randomized control trials. And generally speaking, a well-designed randomized control trial would be superior to an observational study. So that's what Bergeau was talking about. And so if you have a lot of observational studies, the quality of evidence will be degraded because you're going to attribute a grade once you've done the study. And then even if you have a lot of RCTs, you still have to look at the level of bias. So to the question of Dr. Nourou, the study is relevant to what Bergeau was saying. Although they only said meta-analysis, that's definitely a mistake because they didn't respect the PRISMA reporting guidelines. What they should have called this study was all the title and then 2 dots say systematic review with meta-analysis.
Yeah, thank you very much, Roderick. Well said. And then we should go ahead. I hope everyone understands well what Ulrich reached out and tried to explain well about the title. I know that it is not easy for people who don't have this background, but I think that everything is clear. So also when you take a look on the paper, the reference that you see in the and below of the paper, did you think that this reference is relevant, that this reference is recent? Did in the paper, the reference, they reference that correctly? And also when you take a look about the case study, what they include, this case study is appropriate or not? What do you think about this question about the reference? Because it is important for you when you want to review article to take a look also about the references. So who want to go ahead, please?
Let me go ahead with this. So when we're talking about studies like this one, it is interesting for you to have an idea about what the field is like and what has been published about it. That's the way that that's the easiest way to know whether the studies are relevant or not. In the sense that, not the relevant, whether the references are relevant or not. So first of all, what we have to do here to answer that question by Dr. Nourou is look at when the study was published. The study was published in 2018. So we have to look from 2018, where the references recent enough to give information that we can feel like they were actually covering this. And another thing we can do is not just look at the dates of the references, but equally look for landmark papers on the topic. and landmark authors or their papers. So when you're talking about ETV, endoscopic third ventriculostomy, anybody talking about this topic, there are two names that you cannot not see in the references. There is Kulkarni, Dr. Kulkarni, and then there's Benjamin Wolf. So when you're looking at the references, if you just go down to the references, if everybody has it in front of them, or if you just type Control F to find, you're going to find Kulkarni, you're going to find Benjamin Wolf. Another name that you're going to find there is Albright. And you'll see that those are the landmark papers whenever you're talking about endoscopic third ventriculostomy. So definitely the references in these articles are very relevant in terms of time, in terms of like the landmark papers talking about endoscopic third ventriculostomy. We can definitely answer that yes, the reference is relevant.
Yeah, I'm agree with you, Ulrich. Thank you to give answer. And I hope everyone is. I hope you are there, guys. We want all of you to be more interactive, please. And if you don't get some point or you don't understand what something, please don't hesitate to stop and to ask your question, please. So now we will, I think we will go now to the introduction about this article. And I will ask you to know, is it clear what is already known about this topic when you read the introduction of this paper? When you read it, do you feel that you get some background data you know about this topic? Like I think that all of go ahead. Thank you. Go ahead.
Yeah. I felt that although the introduction was brief, I felt like it highlighted the important things to know about hydrocephalus, but also I felt like he didn't talk much about the pathophysiology of non-communicating hydrocephalus and why this is important into, I guess, why it's important for us to differentiate ETV versus ventricular peritoneal shunt. So.
Okay, if I get well your point, you mean that in the introduction was so brief and you didn't find pathophysiology in the background that may help to define, to try to get what they, when we take a non-communicant hydrocephalus.
Yes.
Okay. I get your point.
Hello, Dr. Nourou.
Another, yeah, please go ahead. Thank you.
Thank you. All right, so personally, I think the introduction, though it's short, as the previous speaker just already said, I think it actually does what an introduction is supposed to do, because basically an introduction is supposed to like present the problem at hand, briefly present what is known about the situation that is at hand, and then create some sort of knowledge gap, like, okay, this is what is known, this is what is needed. So how do we fill this knowledge gap? And I think this introduction rightly did it, because he introduced, I like tried to give a brief definition of non-communicating hydrocephalus, and then it went on to present the two methods that are being discussed here, and somehow give us like whet our appetite, like tell us what is, what the work is going to be all about, creating that knowledge gap, and then telling us on how they intend to go about filling this knowledge gap. So I think they did a great job with the introduction, personally. Thank you.
Thank you very much for your answer. I am agree with you also. And to answer you, in my opinion, also the introduction is brief, but it is clear about what we know. Because if you go to the title of the article, they want to compare the management, the surgical management about hydrocephalus. And when you go through the introduction, they talk about what we know about ETV and VP shunt, and what we know about non-communicating hydrocephalus. So in my opinion also, I am totally agree with. In my opinion, it is clear what is already known about this topic, and also when you take a look about the research question. Sorry, I think I am going to the second question now. So I don't know if you agree with us. Please, when you take, please present yourself, because I didn't have you in front of my phone, so I don't know who is talking to me. So please just present yourself when you want to talk, please, like that I can get a feedback and just to know who is talking, please. So I don't know. Who say that he didn't he's not agree. I don't know if you get our point now or not, or you think that it is still not clear, this introduction.
Oh yeah, I agree with what you said. I mean I did say that although the introduction is brief, it does highlight the important things. I just felt like it didn't fully. My name is Michael Barrymore, by the way. I just felt like he didn't talk. I guess spend a little bit more time describing what non-communicating hydrocephalus was for, the laymen that don't fully understand that. But I agree with you guys.
Okay, thank you very much. Thank you. So now I'm gonna, the second question is the research question clearly outlined in your opinions, Michael, or other one, please?
I believe the research question was clearly outlined. It clearly kind of talked about at the end of the introduction what the point of the research is about, what the point of the study is about, which is trying to determine like the treatment effects of ETV versus VS in this particular population of patients. So I think that was clearly outlined.
Thank you. Yeah, I'm definitely agree with you also. Thank you very much for your answer. Okay, so another one, I want to say something about the research question, or we can go ahead, please, guys. Guys, girls, I know all of you, please, can you be more interactive, please? So we should,
hello?
Yeah, go ahead. Thank you to come. Can I have your name, please?
Okay, Dr. Daniel Safari from DRC.
Okay, great.
Okay, what I can say about the research question, I think it's justified. As they stated earlier in the introduction, they outline the fact that there is no evidence and any research conducted earlier on the subject to establish whether there is a given strategy defined earlier to address the treatment of hydrocephalus surgically. Will you just use ETV or shunt? So they also stated that there is no much evidence on the fact, and that is the fact that lead the surgeons to rely on their experience only. So I think regarding the fact they presented in the introduction, we can say that the research question is justified by the literature.
Okay. Okay, thank you. Yeah. Okay, another one, or we can go ahead. Okay, then is the research question justified given what is already known about the topic? When you read this introduction, what do you think if the research question justify? I think that you mentioned that little bit, Daniel, but I want if you're still there, please. What do you think about this research question? Did this research question justified given what is already known about the topic about ATV versus the patient for non-communication hydrocephalus management?
Yeah, I think that the research question is justified. This related to the fact that in the introduction, they said that to what is known actually, there is no protocol to choose between ATV or VP chant. And most of surgeons do rely on their experience only. So they aim to compare studies in order to bring on evidence to help surgeons to decide whether ATV is superior to VP shunt or they are equal. So that's what I think.
Okay, thank you very much for your highlighting. So okay,
another one. Dr. Nourou,
yeah,
Ulrich,
go ahead, Ulrich. Yeah.
Okay,
yeah,
so
I know your voice.
if everybody has the article open, I recommend you go to the last paragraph of the introduction. This is
exactly
why do you want to go there? There is a mention of a couple of previous meta-analyses that have actually gone into evaluating ET versus VP shunt for non-communicating hydrocephalus. But the question here is, if we're talking about, if we're trying to answer the question asked by Dr. Nourou, it's really important, first of all, to be mindful of the fact that it is not exactly true that there is no evidence about that. First, we need to understand why a meta-analysis is important and what the role of the meta-analysis is. A meta-analysis can only exist if evidence already exists. The only way you get to do a meta-analysis is if there have already been publications, right? So you cannot publish, you cannot do a meta-analysis if no one has published something. So once studies have been published, the meta-analysis job actually is to, as it says, you've already analyzed, all the authors have already analyzed their patient data. You're doing an analysis of disorder analysis. That's why it's called a meta-analysis. So you bring all these studies together and you try to compare. What are they trying to compare here? They're trying to compare ETV versus VP shunt. That's the first thing to keep in mind. But if you're looking at the last paragraph, first sentence, a previous meta-analysis found a similar therapeutic effect between ETV and VP shunt for non-communicating hydrocephalus. So the next question you have to ask yourself is, how is this meta-analysis going to be different from the others? They go into the next sentence after reference 19. However, the treatment effects in patients with specific characteristics have not been elucidated. What they mean here is that they're going to go into subgroups, which is what you call disaggregation. Why is this again important? When you read about ETV, endoscopic third ventriculostomy, one of the things that will come up very often is the ETV-SS, which was mentioned here, which is basically a success score for you to predict if ETV will work. And if you read about the creation of ETV-SS, you find out that age is very important in determining whether ETV will work or not. Beyond a certain age, ETV success is very, very low. So you now need to think about, okay, so what I expect from this study that will be different from the others is that they will be disaggregating data. They will be showing me for this patient population with the numerous other things. And then the question for you would be, what are the different causes, for example, of non-communicating hydrocephalus, and what are those things that can affect success of either a VP shunt or an ETV? So that is what you keep in mind. So it's not exactly true, in summary, it's not exactly true that there wasn't evidence. Studies have been published, especially meta-analysis have been published, but what they are trying to add here is a layer of like disaggregating the data, so finding subpopulations.
Yeah, thank you, Ulrich. Then I'm totally agree with what you said, and yeah, indeed, in my opinion, also the research question justify given what is already known about the topic, and that they want to go more and to try to define. That's what also clear. They attempted a comprehensive examination of available studies to determine the best treatment strategy for non-communicating hydrocephalus and evaluate the treatment effect on ETV and VP shunt in a specific subset. So that gives something new about what previous known in the previous meta-analysis. So thank you. If everyone is okay, I think we should go ahead for the methodology properly. I don't know if someone has something to say, a comment before we go ahead, or if it is okay for all of you, we can go ahead.
Hello?
Someone? Yeah, Hugo, okay. Yeah, I recognize your voice also. You can go ahead. Thank you to welcome. Thank you, Tom.
Yeah, thank you all for this wonderful talk. And what level are we now? Have we done with the introduction? Are we at the methodology level or?
No, we finished introduction.
Introduction, okay.
Now
about the methodology, yeah. I will start with the third point. The third point is, are the study methods valid and reliable? That's what I'm saying. Yeah, the study method is valid and reliable because the authors have described in the study that they were going to do this preferred report. How you call it? Preferred report item for systematic review and meta-analysis. These have been stated at the beginning of the study. And sorry, let me close this door because there's a noise coming from the background. Okay. Hello? Hello?
Yeah, go ahead.
Okay,
yeah,
so I'll say that the authors have stated clearly at the beginning of this study that they were going to do meta-analysis and the systematic review. So it's been stated clearly, and in the methodology, the mention all it takes. I don't think it's necessary to go into it in detail. The mention all they've done and the way it should be done. I mean, collecting the information from the sites, from the different sites. So after then, they got I think 1,842 articles. Dr. Iluk just said now, if people don't publish, you won't be able to do meta-analysis. So we have to lay on some original publication from institutes and or anything that can be helpful to go ahead with the meta-analysis. So they got those articles, they downloaded them, and they've shared the way they went about each article. So you can see inside there, they say 2 authors searched the articles, 2 of them, 2 investigators. Whenever they disagree, or someone, a third person is coming, or a group discussion is going on to sort the disagreement. I think that's how it should be done, and they did it very well and reported quite good. And then let me see another part of the second point is the variable defined and measured appropriately. Yeah. The aim of their work, as I understood, is to compare the ETV and the ventricular stenostomy. So they end up getting 10 articles, 10 studies about this comparison between the ETV and the ventricular stenostomy, and that's what they used for the study, which have been well reported in the study characteristic. At the point 3.2. And the first point is the process of study at selection. I can't see it very well. I don't know. Could you please bring back a little bit?
Sorry.
You've taken away what the point that.
Yeah. I'm sorry. I just want to unmute myself. Yeah.
So the process of subjects selection is clear. Yeah. For that also, we can answer that the process of selection is very clear. For this kind of study, is necessary to go on with meta-analysis. It's necessary to go on with analysis. And the last thing I wanted to share with you is that their study, the way they laid down and then did the flow chart. You can see the flow chart down at the end of the the result, you know. The way they put it is very easy to be replicated. And every scientific work should be a work that anyone can take and replicate. If you are doing a scientific work and people are not able to replicate your work, that means something must be wrong somewhere. But these people, these authors, I think they've done great at that point. Thank you.
Okay, great. Thank you very much, Dr. Hug. I think everything is clear. I think that you answered the 3 points. Before is the process of subject selection is clear. I definitely agree. I don't know if someone has something to say about the methodology before we go to the result, please.
You know, I want to share with you guys. The editor-in-chief of neurosurgical. How do you say it? What neurosurgery?
Yeah.
No, it's not one neurosurgery. The actual, Emory, Professor Emory. He's the editor-in-chief of neurosurgery. Yesterday, I was watching one of his videos, and he was like, when I got an article, the first thing I look at is the result. Because I know that the methodology is somewhere you can just take and manage and make it at your own set. It's the result. So just once we share it with you guys. So
thank you very much, Rick. Thank you very much. Yeah. So I don't know some go ahead. But I didn't recognize this voice. It's Michael?
No, it's Chipkem.
Okay,
go
ahead.
From Nigeria, about methodology, talking about study methods, if they're valid and reliable. Yeah, they actually use all the required things under the PRISMA protocol. My only issue is they only pick studies that were published in English or Chinese. There are other studies that might have been published in other languages and they might have missed that. And then they only use a few database, PubMed, EMBase, the China National Knowledge, in regular internet, and then Cochrane. There are other databases they could have used, like COVID, to probably get more studies that might have they might have met their selection criteria. So I don't know. Yeah, so I just think they should have use more languages and more databases. Yeah.
Okay, I get your point, but I mean that authors they define what they want to search and they define their own protocol. But yeah, I'm definitely agree with that. But this could be maybe the limitation about the work. I think maybe we can include that in the limitation about their work. I don't know what you think.
That's the part of the limitation of their work. They didn't include that in their inclusion criteria.
Yeah,
Because they state in their inclusion criteria that they included patients with non-communicating hydrocephalus, patients receive ETV or ventriculocystomy, and the study reported at least one of the following outcomes: improvement of symptoms, major complications, all those. So their inclusion criteria are very clear and they stick to that. If another study is going on and that study wants to go on and include, you can do a study and say, okay, I want to include articles that have been reported in French and English, or certainly in French, or in English, or both, or in Chinese, or in all those, any language you want. But I think that cannot be something that we can see it in the wrong way of this study. It's their choice. They mention clearly the inclusion and exclusion criteria. The exclusion criteria are very clear, and the inclusion also. So I think that's okay.
Hello, everyone. So Ulrich here.
Go ahead, Ulrich.
Thanks for your contributions. When we talk about methodology here, I think it's important to divide it into two. As mentioned above, there are two components here. There is a systematic review on one hand, and then there's the meta-analysis. You've all done a great job discussing the systematic reviews. what Chibuikem said is definitely worthy to note. But I agree with Dr. Nourou and Dr. Hugh when they say that it's a limitation. It's a limitation that you just have to put it out there. When you're doing a study, obviously you want to make sure that you're covering as many languages as possible. And if possible, even have no language barriers. Unfortunately, you might be limited because you don't have the funds to have a professional translator. And in that case, what you do is you take the languages for which the authors are proficient. In this case, the authors are Chinese native speakers. So they took English and Chinese. So it's absolutely understandable, but still it's a limitation. So Chibuikem, you're right in mentioning that, but we cannot hold it too much against them. The second point about the other databases, it's definitely justifiable. But with these, there's always a question of how much more do you get. So when you're talking about Ovid Medline, if you get Ovid Medline, PubMed, and Embase, you're going to get a lot of duplicate information. So it's always good to choose one. If you're getting Ovid Medline, it really isn't a good idea to get PubMed and Embase. If you're getting PubMed and Embase, it's not a good idea to get Ovid Medline. So it's good to choose between either PubMed, Embase, and Ovid Medline. I think what you could have added there is perhaps to say, okay, how about we include more low and middle income countries, for example, by searching Global Medicals Index, for example. So that is one thing they could have added. But in terms of methodology that we need to mention here, they did not mention a protocol before the study. When you're doing a systematic review, you need to write and register the protocol. So when you're registering the protocol, you register this for systematic reviews, you register them on Prospero. So if you type Prospero, you should find the website. You register systematic reviews there. You cannot register other things like scoping reviews. For example, for scoping reviews, you have to register them on other platforms, for example, Open Science Framework. But that is something that you mentioned. Why is it important? Because when we have a protocol, we can say, okay, this protocol was developed before the study, and we can make sure that the authors followed what they had planned to do, that they didn't go do what we call data dredging. Because if you don't define a protocol, you just go and analyze stuff, and then you decide that whatever is statistically significant, that's what you're going to be reporting, then it is a major bias. So it's always a good idea to register your protocol and then give information about where that protocol is housed, usually Prospero for systematic review. Now, the other thing that is really important to discuss here in the methodology is for those that have the document, the article in front of them, I recommend that you go down to statistical analysis. Statistical analysis is the part on the meta-analysis. I think we've discussed a lot of systematic reviews here, but we haven't done a lot about meta-analysis. So like we said, meta-analysis is that a process of you collecting data from the individual studies and pulling them together to find out what the effect is like from these pooled data, but equally to find out the level of bias and heterogeneity. So whenever you're looking at meta-analysis, one of the things that you want to take a look at is how the authors decide to calculate the differences or effects in the different populations. So one of the things that they chose here was the standard mean difference and the 95% confidence interval, which you will find in the second sentence, which is after references 23 and 24. But more importantly is heterogeneity, often calculated using the I-square. So what heterogeneity does is it tries to, it gives you an estimation of how much difference exists between the study populations. One of the simplest things we spoke about was the age. When we get down to the results, you will take a look at the table of summary findings, look at the mean age for the different studies, and you will notice in that table that all the Chinese studies had adults. You see the mean age, but the non-Chinese studies had a lot of young folks. And remember that age is a determinant of success for ETV. So if you take a look at that, then you look at what proportion of patients were children, which is all the non-Chinese studies, we find out that it was overwhelmingly in favor of children. So you need to be careful when you're interpreting the results. And what helps you do that is that heterogeneity, so the I-square value. So you have to look at that. What is the heterogeneity like, and what is the p-value for that? And then finally, another thing that we have to look at when we're talking about meta-analysis is the funnel plots. So the penultimate sentence, it starts with funnel plots, comma, Egger et al., comma, and Bergen. So what are funnel plots? There are these plots that look sort of triangular with dots on them. So when we go to the results as well, I'll re-explain what it means. What the funnel plot does is that appreciate if or assess if there has been any form of publication bias. What publication bias is that when you submit a study to a journal, the tendency is for journals to only accept studies that show positive results. Journals don't like to publish studies that have negative results. So positive as a negative result is you make a hypothesis. Say your hypothesis for your study was ETV is better than VP shunt in every aspect. You do your study and you find out that that's not true. A lot of journals will not accept to publish those kinds of studies. So what happens then is that studies that have that show mild or negative results will often not get published. And so when you use the funnel plot helps you assess how much bias is in this field. And another thing you need to keep in mind is that be very careful of interpreting the results of meta-analysis that have 10 or less studies. Whenever a meta-analysis has 10 or less studies, the results from the meta-analysis, you should take them with a grain of salt. So ideally, for a meta-analysis, you should have 10 or more. If you have 10 or less, it really isn't very helpful. So as a summary, in meta-analysis, look at how you're going to calculate the pooled data. Here, it's done by the standard mean difference. You need to appreciate or assess the heterogeneity. Here, they did it using the I-squared. And finally, you need to appreciate or assess publication bias. Publication bias here was assessed by using the funnel plots. So when we get down, we'll talk more about those. Thank you.
Yeah, thank you very much, Greg, to highlight everything in this session of methodology. I hope everything is clear for everyone, and we can go ahead. Or if you have if you get confused, or if you have some question, don't hesitate, please, to ask. And please be more interactive, please. So someone want to say something about this methodology, or it is okay for everyone, we can go to the results. Okay, great. So we will go. Yeah, we will go to the result. Thank you. When you go to the result, is the data presented in an appropriate way? That means the table and the figure is there relevant, clearly presented, appropriate units, rounding a number of decimal, the title, the column, and row label correctly and clearly, category group appropriately. What do you think about the data presentation? I think we have 2, 3, 4. Okay, great. So we have 8 figures, and we have 2 tables. Yeah. So what do you think, guys, about the presentation of the data? The flow diagram of the screen.
The result for me, I think is okay, but what I don't understand is that I don't know why at the beginning of the result they were forced to come back again with the literature research, because in the methodology they've said how they carry on the research, and it's kind of repeating themselves in the result. I mean, the first paragraph for the result, where they put the literature search. I don't know if it's necessary to be there.
In my yeah, someone want to go ahead? Yeah, go ahead, please. Hello? Hello, someone want to go ahead?
Even the result, well, they put, they have laid down what they've got and the meta-analysis they've done.
I think
with the flow chart,
in my opinion, I think that it is not bad. It is relevant also to reach out to what they reach out about the search. It is also the result of what they do. In my opinion, I think that's not bad what they do. In my opinion, it is good to reach out because here they explain literally that how much article they retrieved from the initial literature search, and how the way that they excluded the duplicate and the irrelevant, and finally the 61 potentially eligible study were selected, and also they excluded 51 study because that they didn't find, because also it is important to understand why after to search 1,842 articles, finally it is just 10 observational study they include. So I think it is what they do. It is good because they show us that they exclude 51 study because they didn't find appropriate control, no sufficient data, and animal studies. And why that it is the best way to minimize the bias on your data extraction. So in my opinion, it is not bad what they put about the literature search. I don't know if someone wants to say something about Hugues' comment. It is okay for you. You are not agree that maybe they should not.
Well, I didn't say I don't agree on that. I just say I don't know why.
Okay.
I'm just wondering why they have to come back again in the result session to repeat themselves about how they carry on the study. That's just what I'm saying.
Okay. No, in my opinion,
I just want to understand. I don't know why.
Yeah, in my opinion, it is important. It is important because it is good to give more detail in your methodology, and also in your result. It is nice also to reach out how you made also how you include. How much article you include, and yeah, exactly how much article you include, and the way also that you do that. I think it is nice. So now, my question is about the table.
Yeah. I would like to comment on the results.
Go ahead.
Yeah, I'll just share my screen, and I think it should help answer Dr. Hugh's question.
Okay, you want me to stop my screen? Okay, great.
No, it's fine. Thank you. So whenever the very first results of your systematic review should always be what they give you here. You should always start by saying, this is very different from the search strategy. This is not a search strategy. You have to explain step by step what you did. So, and this must always be accompanied by this figure. The first figure of every systematic review or scoping review should always be your Prisma flow diagram. The Prisma flow diagram gives information so that people understand how you did your study step by step, because scoping and systematic reviews are meant to be step by step. So you have to tell the readers how many duplicates you took out, which is what they said here. You need to tell them how many you excluded and why you excluded, a title and abstract. So one issue here is that they haven't given titles, because they should say here that the record screened here were title and abstract screening. They did a good job here saying full text articles assessed. So this is full text screening. And finally, we know how many studies were included. And really good is that they tell us the reasons for exclusion. Very important. So on this aspect, this is a very good table. And those results are definitely relevant. If we go down to other studies, I think, let me try and get this blown out so that we can take a look. Just give me, let me get the PDF. It is really important to take a look at this because they've done a fantastic job. And in fact, that question by Dr. Hugh is actually part of the PRISMA reporting guidelines. You must always give this, this table. I just want to zoom here. Okay. So here, when we're talking about the next thing is after the figure one, the table one is always the characteristics of the studies you included. So see what happened here. If you're doing a systematic or scoping review, your figure one comes first. It is the PRISMA flow diagram. And then the next thing is this, which is the summary of study findings. And here you have to label always the authors, publication year, give data about the countries, the study design. This is very important. I think someone commented about this in the beginning. I'm sorry, I forgot who did. I think, oh no, it was Bejo. So here, yeah, study design. Study design, this is not really a study design. This is a mistake. When you say prospective, that's not a study design, or retrospective. This is not a study design. So study designs, this is not enough information. It would be more information if they said, for example, if it's a retrospective cohort study or a prospective cohort study, but say whether it's a cross-sectional study, whether it's a cohort, whether it's a case control, whether it's a randomized control trial. Because when they don't give it here, it's difficult to appreciate the level of hierarchy of evidence. But what everyone should be paying attention to definitely is starting here. Look at the sample size. The sample size here is 1,209. This is the highest sample size, right? And then the lowest sample size is 40. But equally take a look at the year publication years. This is equally important because as we advance, things change in terms of what we are understanding and standard of care. So when you take a look at this, what this tells us is that the studies that were not from China had more patients than the studies that were from China, a lot more patients. So this is going to impact. But look at this as well, when I mentioned before, the mean age of the population. In Kulkarni et al., they decided to recruit patients less than 18. This is not a mean age. This is what the inclusion criteria, less than 18. So pediatrics, 5 years old, pediatrics, 4, pediatrics, 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 pediatrics. But when you come to the Chinese studies, notice how you have a jump, 34, 21 years, 35, 22.3. So all the Chinese studies have almost only adult patients, and all the non-Chinese studies have children. So that should already get your attention. Next thing is sex, because sex is very important in the ETV success score. When you get time, please read about it. Age and sex, they're very important in this. And take a look at how most studies did not report NA, not available. Most studies did not report the ETV SS. So they didn't report that. So it's difficult to assess on that. We know the disease type already. So very good information. We get to follow up. Very, very important. Always think about follow up. Why? There's this saying in surgery that if you do not have complications, it's one of two things. Either you're not operating or you're not following up your patients. Someone that does not follow up their patient always has a 100% success rate because you will not see the patient to see the complications manifest. And so it's important to see how long these patients were followed up for. Very important information. And finally, reported outcomes. Why? If there's heterogeneity in the outcomes reported, then it's equally difficult to appreciate these outcomes and their effects. When you take the first study by Kulkarni, notice how the only reported outcome was improved symptoms, improvement of symptoms. But in other studies, you had a little bit more, like major complications, hematoma reoperation, mortality. And obviously you have the Newcastle-Ottawa scale, which I recommend you read about. So this table is very informative. They could have added more information by adding study design here. You have to pay attention as a reader on the sample size, the mean age,
and some of the follow-up the follow-up in the studies, as well as the outcomes, because they told us in the beginning what they're trying to determine here is how ETV compares versus ventriculoperitoneal shunts in terms of reported outcomes. Now, this here is, I understand some people might not be familiar with this, so I'll try to explain this. Remember, they said they're going to calculate as the standard difference in the mean and report the 95% confidence intervals. For those who've been with us before, they'll find this easy to interpret here. I'll speak about this first, and then I'll come to this, the title of the first author, the name of the first author. So when you come here, what does it tell us? This is simple, the weight. The weight is the population. Remember how we said, just coming up here, remember how Kulkarni had 1,209 patients, right? So that amounts to 24.4% of weight. It's important to take the weight into account because then it will affect your interpretation of results. Study with smaller sample sizes will have less impact on the pooled analysis, which is this overall. So when you're looking at this, you take into consideration the weight. And when you come to odds ratio, an odds ratio of 1 means that the two things you're comparing, in this case, ETV, endoscopic third ventriculostomy, and VS, which is ventriculoperitoneal shunting, are the same. So if you see anything close to a value of 1, then it means that the two are the same for the comparison. If you see anything above, then whatever is the numerator is superior. And if you see anything below 1, whatever is below is superior. So for that, you need to know what is above. So here they're comparing endoscopic third ventriculostomy on the incidence of improvement of symptoms when compared to ventriculoperitoneal shunt. So the numerator is endoscopic third ventriculostomy. The denominator is ventriculoperitoneal shunt. So when you come here, any value above 1 means it favors endoscopic third ventriculostomy. So in Kulkarni's study, because it's 1.93, it favors ETV. In de Ribaud-Pierre, why? Because it's less than 1.03, it means it favors instead the ventriculoperitoneal shunt, and so on and so forth. But that's not where you ended. You now have to look at the 95% confidence interval, these values here. You have to look at them. So what are you looking for? You're looking for the lowest value and the highest value and see if between the lowest and highest values, you can find the figure 1. So between 1.53 and 2.43, you can have 1. Because you can have 1, then this is statistically significant. So let's take another one. Between 0.16 and 1.40, if you had to put down all those numbers, you have the figure, you have the number 1, right? So because you have the number 1, this result is not statistically significant. However, this one is statistically significant. So this first study that favored VP shunting, the results were not statistically significant. It doesn't mean that VP shunting didn't work. It just means that you don't have evidence that it was working, because it's very important in the interpretation. Let's look at this second one. 1.06, it slightly favors endoscopic third ventriculostomy. In fact, some will even say that it's the same because it's close to 1, right? And you can see that it's on both sides of 1, from 0.5 to 2.25. And so for this reason, this result is not statistically significant, and so on and so forth. So here, the first thing we did was we interpreted the odds ratio. The second thing we did was we interpreted the 95% confidence interval, okay? Now that we've done those two, this is what this diagram is showing us. If you don't want to waste time looking at this, you can come to the diagram. How do you do that? So what the diagram does, often it's not rectangular. Most times you'll see this form. It's not usually a rectangle, but it's fine. So this is the line. So remember, we said if it's greater than 1, it's in favor of ETV. If it's less than 1, it's in favor of ventriculoperitoneal shunt. And just by looking at this study, we can tell that from all this study, 2 of them favored ETV, whereas 1, 2, 3, 4, 5, 6 favored ventriculoperitoneal shunt, right? And then there was this one study that was in the middle that did not favor either ventriculoperitoneal shunt or ETV. Then the next thing is, once you've spoken about the box, the next thing you want to do is, or let me just make this, it's the center of the box that you're interpreting, not the entire box. So if it's this kind of a shape, you're looking at the center. Now, the next thing you want to do as well is you want to look at these lines. These lines are in fact the 95% confidence intervals. And if you remember what I said, when you have the 95% confidence intervals, if it has 1 in that interval, then it is not statistically significant. So what that means literally in the diagram is whenever the line crosses this line of 1, then the results were not statistically significant. That's what you're seeing here. They were not statistically significant, all of these. So ideally, these would have been on this side without the line crossing this here. So that is another interpretation. And obviously, when you look at the overall, so this overall has taken all this into consideration. And it shows us that for the overall will have a value less than 1. So favoring ventriculoperitoneal shunt, that's what you see here, 0.83. But it crosses the line of 1. So it's on both sides of the figure 1. So that's why it's 0.46 to 1.50. And as you can see, the p-value, without even looking at the p-value, I already knew it will not be less than 0.05 because it was crossing this line here. And these people could have done more by also reporting the p-values here. And so that is how you have this information. Now, remember we equally said you have to appreciate or assess the heterogeneity. This is the heterogeneity here, the I squared. So not only you see how much heterogeneity is there, here 59.7%, but you can equally tell if this heterogeneity is statistically significant. Here it's less than 0.05. So based on that criteria, we'll say there was a lot of heterogeneity. And that is how you explain or interpret this here. Now, if you were going to articulate that in words, then you will find that because the value is less than 1 in favor of VP shunting, you say no, what you found was that there was a difference between VP shunting and ventriculostomy, but since the p-value is not less than 0.05, you did not find evidence that this difference is actually true because it's p. You don't say it's the opposite, please. So when p is not statistically significant, for example, if you were saying ETV is better than VP shunting, if it's not statistically significant, you don't say, oh, VP shunting is better. No, you just didn't find evidence to support that. That's how you interpret it. And then this is same concept. Just think about it. Lower confidence interval limit, upper confidence interval limit. This is for different things. For example, improvement of symptoms. So maybe I shouldn't go too fast. Remember, if you're looking at odds ratio, you're looking for 1. So 1 will be somewhere here. And then you'll be looking at, for example, Kulkarni here. Kulkarni has values. Here's the estimate. Here's the lower limit of the confidence interval. Here's the higher limit here, right? And this is the pooled value that they gave you here. And so you can interpret that. You can interpret this as well. So you can do it. You can bring it out for everything and then do the interpretations. Here, for example, look at this. This does not cross the value 1. So we know the p-value will be less than 0.05. Look at that. Great. And what does it do? It's in favor here on the other side. And so they went ahead and did subgroup analysis, same concept. Remember again, you look at this box, where is it on the side of 1? Does it cross the line? So that you can get an idea of the p-value. And as you can see, you can interpret that. You can interpret heterogeneity as well. And they did a lot of those. But what I want to go as the last is this, the funnel plot. So this is the funnel plot. You can read on it. And the funnel plot helps us know if there's publication bias. So normally, if there's no publication bias, we should have a homogeneous distribution, where whenever we have this kind of a distribution, which is skewed to one end, we think there is a possibility for publication bias. Now, the funnel plot is not always accurate because it depends on the number of publications you have in that field, but it definitely helps us know if there was publication bias for each of the aspects. So this is the funnel plot for publication bias in improvement of symptoms, major complications, and so on and so forth. So that is how you interpret this. Then when we go to the discussion, I hope you will better understand what we meant. Thank you.
Okay.
Okay, thank you. Thanks a lot.
To reach out everything. It is lovely and great, and I hope that everyone understand well how to interpret the result. I know that you should repeat that, and it's not, I know it's a little bit complicated, but you should repeat, and to try to understand. If you don't understand anything, you can reach out to Dr. Ulrich, me, or you. Anyway, I believe that it will be done. So now, thank you very much, Ulrich, and we should go ahead for the next, I think, for the discussion. Can I share? Okay, great. I can share now my screen. Okay. Okay. So now about the discussion. So does the test? No, it is okay. I think that we did everything in the result. The conclusion. Okay. Are the results discussed from multiple angles and placed into context without being overinterpreted? If you go to the discussion, what do you think about the discussion? Did the result discussed from multiple angles and placed into context without being overinterpreted? Then if you want to share also the discussion, I think I opened that here for everyone. No. Oh my God. Anyway. Someone wants to go ahead?
Let me share to make it easy for you.
Okay, thank you. Yeah.
I think everyone can see this here. This is actually the final discussion here.
Yeah.
So as it says, yeah, findings from this meta-analysis suggest that ETV was not significantly associated with incidence of symptom improvement, hematoma, mortality, while it could share. And then they give the rest of the information. So I think, yeah, you can go ahead and, so that is it.
Yeah, thank you. The findings from this meta-analysis suggest that ETV was not significantly associated with incidence of symptom improvement, hematoma, and mortality, while it could reduce the risk of major complication, infection, and reoperation. Because you know that in the case of V patient, you may have infection, you may have reoperation. And but the thing that I see here, it is when they say that when they made the comparison about the treatment effect, because for neurosurgeon it is how can I say, we take things in this way. What is the effect about our management? So when you take the comparison of treatment effect for ETV and V patient in patient with a specific characteristic, they say that another important meta-analysis only provides the incidence of failure rate and focus on quantitative analysis. So therefore, they conduct a comprehensive and quantitative analysis of available studies to compare the efficacy and safety. And there was no significant difference between ETV and V patient for the incidence of symptom improvement. And so okay. So for me, I think that they interpreted the effect, and they see that there was no significant difference between ETV and the V patient about the risk of hematoma and mortality. And also they try to explain that. So for me, I think that when they say that the reason for this could be that few events occur in each group, and this study design symptom index as primary outcome, and the sample size of this study were not sufficient large to detect significant difference for hematoma and mortality. So also they try to explain their result and to discuss that. But furthermore, they noticed that ETV was correlated with lower incidence of infection and reoperation than V patient. So the possible reason for this also could be that V patient was associated with higher failure rate due to infection and malfunction because when V patient get infected, you should remove VP, we should remove the device and to wait your CSF to be clean before to go ahead to another shunt. But about the ETV, you don't need, if ETV is done success, if ETV is, you get a success after your ETV, you don't need to come back to report, just maybe in follow-up at long term, maybe sometimes you can get obstruction again and you should go back again to reoperate in ETV, but when they try to compare, ETV was how can I say that, better than V patients in non-communicating hydrocephalus. I don't know if someone wants to say something.
Yeah, I think you gave most of the information. This last what Dr. Nourou said about the discussion, what the authors actually mentioned, is very important, and you need to pay attention to it. Remember this: when you're doing a meta-analysis, again, it sounds simple, but it's very important. You're reanalyzing something that was already done, was already designed. Why is it important? When you design a study, you have primary outcome and you can have multiple secondary outcomes or many primary outcomes. And when you do that, generally the study is designed for the primary outcome, not necessarily for the secondary outcome in terms of the number of patients recruited. And if that is not the case, you might end up looking for, say, complications, for example, and your p-value is not statistically significant. And like I said, the fact that p-value is not statistically significant does not mean there are no complications. It means you did not find evidence that there were complications. That's very different. And why is this important? Because it comes to the concept of power of study. That's why when you're doing a study, you need to calculate your sample size, but calculate the sample size for each outcome if you want all the outcomes to be statistically significant, and find a strict minimum to use it. If you only do it for the primary outcome, it's possible that the secondary outcomes might not show statistical significance, like it was the case here. These authors went ahead and did this, right? Where they took all the studies and then they compared them, they dichotomized them, they decided, for example, publication year after 2010, 2010 or before, and so on and so forth. Just look at the odds ratio or directly here at the p-values. If you're looking at the p-value here, the first one that shows statistical significance is when you're thinking about major complications, the year of publication is important. Look at that. So depending on whether the study was published before 2010 or 2010 or before, after or before, you find that there is a significant difference. When you look at the income status of the country where the study was published, depending on whether it was a high income country or a low and middle income country, you see a statistical distinction. And this distinction continues in the type of study design as well. So study design equally influence whether you could detect these differences. And look at that age. We mentioned it in the beginning. We spoke about sample size, less than 100, more than 100. We spoke about age, pediatric or adults, very important in this. And that is why when you look, you remember that very first table, we were getting your attention, attracting your attention on sample size, on year of publication, on the type of study design. We attracted your attention on that because these things can impact your results. And this is what this table shows us. This table shows us that there were statistically significant differences between these two groups. And at the end of this, what you would recommend definitely is tell people that, yes, let's try to have prospective studies, preferably more than 100. So if you're going to do ETV versus VP shunt, the recommendation here should be try and get more than 100 patients. Try and get preferably patients of the same age, usually less than 18. And, you know, if it can be a randomized control trial, perfect. Otherwise, look for a case control, a cohort study that will be prospective. And that should be good, especially for major complications, although this does not have an impact on improvement of symptoms. So that is how we would interpret this here. Thanks.
Thank you very much, Ulrich. To highlight more what I was saying, great support. Thank you very much. And then the last point, I think that we will take, and it is about the conclusion and the limitation. So the conclusion supported by the reference or results. When you take the conclusion, they say in summary, the result of this meta-analysis suggested that ETV was not superior to the patient in terms of symptom improvement. So I think that all of us, we agree with that. Further, ETV could reduce major complications in patients with non-communicating hydrocephalus, although there were no significant difference related to hematoma and mortality. ETV was associated with a lower incidence of infection and reoperation. And then finally, patients who received ETV had shorter duration of surgery and hospital stay, but they add that future large-scale randomized control trials should be conducted, focusing on specific adverse events and on the evaluation of treatment effect in patients with specific characteristics. With this last paragraph, I definitely agree. And for me, they didn't. Their conclusion didn't support it about the reference, but about the results. I think that they try to summarize the results, and I am totally agree with the conclusion. I don't know if you want to add something. If now we can talk about the limitation. And also you will see that in the last paragraph, they mentioned that randomized control trials should be conducted. So that means that there are opportunity to inform future research about what they did. Yeah, go ahead, please.
Dr. Nourou?
Yeah.
I don't know. Yeah, can I have the floor a little bit, please?
Yeah, you can. Yeah.
Okay, thank you very much. For my own understanding, like for this particular research, like the authors, since they were comparing two procedures. So for me, my understanding is that for one procedure to be more than the other one, it should be like the therapeutic outcome should be greater. There should be lesser complications associated with it. There should be a shorter duration of hospitalization, and I think little rate of readmission. But now from the method and the result, you will see that the only reason which made the authors not to like conclude boldly that ETV is greater was the fact that there was no significant difference in the therapeutic outcome both. So, but they give at least some points that will make ETV superior to the ventriculoperitoneal shunt, but based on the fact that the therapeutic outcome is not different, so do not conclude on the superiority on one procedure above the other. So that's why they recommend now the further studies, that is a large scale RCT, so that it will help to answer the of the article.
I'm a little bit confused, but I think that what you mean, you think that in the conclusion, I don't know if you get well his point, Ulrich, because I get a little bit confused about what he said. because here here definitely they try to show us that about the symptom improvement. Anyway, when you shunt CSF, there is no the ATV was not superior to VP shunt in terms of symptom improvement. I don't know if you agree with that, Berjo. And then they try to highlight that ETV could reduce major complications in patients with non-communicative hydrocephalus. That's what they carry out after their meta-analysis, and I am totally agree with that. But although there were no significant difference related to hematoma and mortality, because even if you perform ETV, sometimes you can, because you know you go away to the to the basilar arteries, vertebro-basilar arteries. So sometimes you can, sometimes when some vein could bleed in ETV procedure sometimes, and so that's why you can get also hematoma. Also about the mortality, but the incidence that they show that it is very low in ETV. It is about infection and reoperation, and I think that it is very clear. But now, however, they think that the large-scale randomized control trial should be conducted focused on specific adverse events and on the evaluation of treatment effect in patients with specific characteristics. That means what? I don't know. They can take some they can do multicentric study. Maybe they will take, okay, we will take just a pupil with a non-communicating hydrocephalus, maybe with, I don't know, with a stenosis aqueductal. We will study this specific characteristic, maybe for 1,000 or 2,000 population to see ETV and VP shunt, what is the benefit with the same characteristic data with the same how can I say, the variable that they study. I don't know if you understand me, Berjo. Are you there, Berjo?
Yes, I'm there, Dr. Nourou, I'm there.
Okay, I don't know if you get my point, because I was a little bit confused about your comments. Sorry, your English, it is so fast for me.
Sorry. Okay, so what I basically what I meant was that from this article, like the points that will help to know whether the ETV is superior to the ventriculoperitoneal shunt will be one, the rate of symptom improvement, the rate at which complications arise, the hospital stay, and maybe the incidence of reoperation. But now they summarize there that like the thing that will make them not to like give a conclusion that okay, this one is above this one is because they say that ETV was not superior to VS in terms of symptom improvement. So there's only one element that will like help them not to conclude for this on the study. And also there's also one complication, hematoma and mortality. There was no significant.
Make your question concise. No explanations. What is your question?
It's not a question. I was like trying to interpret the conclusion.
Okay, so I guess from what you've said, yes, from what you said, it makes sense. So just careful with the wording. Although they've written this, please do not repeat this. There is no evidence that one was superior or not superior. There's just, you don't have evidence right now to support ETV or VP shunt. That is the interpretation.
Yeah.
Based on these outcomes, you do not have evidence. You cannot say, let's go with ETV. You cannot say, let's go with VP shunt. The conclusion here is for us to know which of VP shunt and ETV is superior at this moment in time. When they published it in 2018, the studies were inconclusive. So what is the conclusion? do more studies. What kind of studies? Randomized controlled trials with at least 100 patients. And while recording these endpoints, what are the endpoints? Incidence of the different minor and major complications. That is the conclusion.